Good morning. Welcome to the Grand Rounds. My name is Alex Wong. I'm R2. Today my topic is on Priapism. I'll present a review and an update. So this topic is, this Grand Round is focused around the AUA guideline on Priapism with a special focus on difficult refractory ischemic Priapism, consideration for implants in Priapism, and also management strategies for stuttering Priapism. So just some background. Priapism is named after the god of Priapus, who is also the fertility god. So as you can see on the right, he has a big manhood. And if you look closely, there's also a string attempting to weight his manhood. So incidence is 1 in 100,000 years, and 95% is ischemic. But in modern days, usually the patient is less attractive, lying supine on bed, penis erect, and desperate for help. They are quite far from being the fertility gods because 50% of them will end up in erectile dysfunction. So it's down to us urologists to do a good job. There's no fair tennis without a net, so let's set some definitions. Priapism is emergency most of the time, so a lot is based on time. It's defined as persistent erection more than 4 hours. Ischemic Priapism is when there's no flow, usually it's very painful. Non-ischemic Priapism is when there's high flow and the patient is usually painless. Prolonged erection is defined as more than desired, but less than 4 hours. Recurrent ischemic Priapism are those with recurrent episode without meeting the 4 hours criteria. The penis is a simple organ. It has inflow artery into sponges, and then blood drains via the veins. So during erection, there's sexual stimulus, and we have parasympathetic stimuli, and this causes release of nitric oxide, cGMP, and cause arterial vasodilatation. And this causes blood to fill up the corpora, increase in pressure, and increase in pressure in turn compress the veins. And this causes erection and increase in the corporal compartment pressure. Things occur the other way around in detumescence. When there's erection, there's sympathetic stimuli, there's epinephrine release, and smooth muscle constricts, decrease in arterial inflow, decrease in corporal pressure, and veins, there's less compression over those subclinical veins, and so blood can drain out from the corpora. Decrease in corporal pressure, detumescence. In ischemic Priapism, the vicious cycle occurs. There's overfilling of the corpora, and there's a very high corporal pressure, high degree of compression of the subclinical veins. As a result, and there's no venous drainage because the corporal pressure almost match that of the mean arterial pressure. It is almost like compartment syndrome, and therefore there's also no arterial inflow. As a result of the stagnant blood in the corpora, there is hypoxia, hypercarbia, and acidosis causes more smooth muscle injury and further dilatation. Irreversible damage occurred very shortly after the Priapism. That's why we have to act quickly. That's 6 hours, there's smooth muscle necrosis. 12 hours, corporal fibrosis. More than 36 hours, irreversible erectile dysfunction in nearly all patients. In contrast, in non-ischemic Priapism, there's usually some sort of injury causing a fistula between the artery and the corpora, and there is, as a result, there's unregulated arterial inflow afterwards. Risk factor of Priapism include sickle cell disease or other hematological disease, medications, malignancy, injury, whereas injury is more related to non-ischemic Priapism. Medications related to Priapism, it's a very long list, so there's always something to blame. So we can always make it make sense by putting it in context of the erectile function pathway, psychiatric medications cause priapism by affecting the serotonergic pathway. Alpha blockers are vasodilators themselves. Erectile dysfunction medications act via the PDE5 pathway, inhibiting PDE5. Recreational drugs increase the sympathetic drive. So the good news here is that the erectile dysfunction medications, most commonly Viagra, Cialis, they rarely cause priapism, and those are only case reports in 1 billion users. The second good news here is that injections we give also does not commonly cause priapism. Trimix is the most attributed agent because it contains papaverine, phentolamine, and these medications has a longer half-life. Clinical assessment of priapism follows the usual pathway for every disease. First, we establish the definitive diagnosis, that is ischemic or non-ischemic priapism. And then we want to establish the severity, that is the duration of priapism. And we want to know whether there's risk factor, so we can do good secondary prevention. And we also want to establish treatment endpoint. We want to know whether the patient has good baseline erectile function. We do so by taking a complete history, physical examination, including examination of the genitalia, examination of the perineum for any signs of injury, abdominal exam for any mass, and also laboratory testing. Key findings for ischemic priapism include painful penis, fully erect with an abnormal blood gas. If the patient has perineal trauma, is only semi-erect and is non-tender, on examination has no pain, it's more likely to be non-ischemic priapism. The following is the blood gas abnormality for priapism. And in case of ischemic priapism, usually the test results are very out of range that the laboratory will call directly. Now, moving on to treatment, phenylephrine injection was first studied in the use of priapism because it is a pure vasoconstrictor with minimal cardiotoxicity, and it has a short half-life. It is an alpha-1 agonist. According to the AUA recommendation, we first have to put the patients in blood pressure monitoring because of the theoretical risk of hypertension. We inject every 5 minutes or every more than that. We inject 100 to 500 microgram each, and we do so up to an hour, or when BP change is noted. There is no clear evidence on the maximum dose of phenylephrine we can use, and AUA defer that to the physician expertise. I've reviewed some literatures as to can we do better on this respect. And there are studies using higher dose of phenylephrine. Read study the use of higher dose of phenylephrine up to 12 milligrams. All 48 patients with less than 36 hours at presentation all has successful detumescence. There was no adverse CVS effect. Moving on to aspiration and irrigation. This is used in conjunction with phenylephrine injection as the first-line treatment of priapism. The principle is to draw blood out from the corporeal body, and this reduces the intracavernosal pressure. Irrigation helps to remove blood clots, which may otherwise prevent the process of aspiration. One article in 2005 by Atia studied the use of cold NS for irrigation because of its theoretical vasoconstrictive properties. And it found that 96% of patients treated with cold NS has successful detumescence. Of course, we have to avoid that in sickle cell disease. Regarding aspiration irrigation, there's different approach for needle placement. The one recommended AUA guideline is 3 o'clock, 9 o'clock at base of penis. But there's also alternative approach. As you can see on the right lower corner, AUA University video on the glands, 3 o'clock, 9 o'clock through the glands. The key in choosing the correct way is to avoid a urethra. Personally, I think the one on the right lower corner is better because experience tells us after reduction of priapism, the penis becomes an eggplant. That's because blood accumulates in the buccal fascia, and this is present on the shaft of penis, but not the glands of penis. So by doing a puncture via the glands of penis, we can avoid blood from trapping in the buccal fascia, and there's no eggplants. And if the patient subsequently requires a dorsal the distal shunt, and we can also use the same incision. So the second line refers to shunting, and there's proximal and distal shunts. Proximal shunt is classified by the way we cut. Distal shunt are classified by the way we cut, whereas proximal shunts are classified according to the type of vessel we anastomose to. There are lots of shunts, and AUA guideline currently recommends the use of distal shunts, and the proximal shunt is no longer routine. And if I were to choose one shunt, I would choose the T shunts recommended by Brandt in 2009. It was designed to overcome the limits of other types of distal shunts. It tests 13 men with priapism with delayed presentation, failed first-line treatment, and half of them failed second-line treatment and some sort of shunts. All patients were successfully taken down after T shunts. Study was done using in the setting of emergency departments, local anesthesia, use of 10 blades. But for my experience, I think an 11 blade is better because it's not as big, and you insert the blade all the way to half the blade, and then usually there will be a gush of blood. The key here is not to look into the penis itself, because usually there's a gush of blood, and not to ask the nurse to stay away as well. Now then you turn the blade away from the urethra, and then you milk the blood out from the penis, and then you suture it back. And if there's recurrence of priapism or failure of reduction, we do it on the contralateral side. Next line is corporal dilatation. We have talked about injecting the needle, doing irrigation in the penis, injecting phenylephrine, stabbing the penis, turning it 90 degrees outwards, and now we can talk about putting a rod into the penis. So we use a size 8 Heger dilator to help to evacuate the blood clots, aiming to better drain the penis. And there's from a study by Sakarakis, all patients result in successful detumescence if it's less than 24 hours, and success rate decrease as time goes along. If it persists despite shunting, next step is to do a penile Doppler ultrasound to make sure it is still ischemic and has not converted into a high flow priapism. We'll also do a blood gas for objective confirmation of a persistence of ischemia. If it persists, next line is penile prosthesis as recommended by the AUA guideline. Penile prosthesis in the setting of priapism is a very challenging situation. So it is essentially about putting in a rod and a cylinder via a perineal wound, while opening the tunicate albuginea of the corpora and shove it all the way along. But imagine if the penis previously had some sort of irrigation, pre-procedure going on with some infection. This will increase the infection rates of penile implants. If the patient has got a distal shunt, this will cause an opening in the distal end, increasing rates of extrusion, and this will and there's previous blood clots, inflammation, fibrosis, causing penile shortening. So put it into perspective. First, on timing, benefits of early implant is that there's less fibrosis, delayed implant being it heals better. Regarding type of implants, inflatable usually preferred by patients, whereas malleable is usually more reliable mechanically because it does not need to be cycled, and it can penetrate better into fibrotic tissue. There are various technical considerations on like the ways to excavate those fibrotic tissues. Now, if there's no best solutions, should be considered one-step procedure or a stage procedure. Now, on timing, Sakarakis done a study on timing on early versus delayed implants, found that early implants, patients usually are happier, they have less complication rate, and there's less shortening. This was proven in a systematic review, including also the previous study, found that there's more complications in delayed implants, There's no difference in erosion. There's more fibrosis in delayed implant. No difference in infection. No difference in penile injury, and higher satisfaction in early group. So far, everything seems to suggest early implant is the better solution. Now, talking about erosion, we know that it's likely due to previous distal shunting causing a gap in the tunica albuginea. Well, there are several approaches, and one of them is to tack malleable implants in the corporal edges. On the right-hand side, you see a patient in dorsal lithotomy position with a perineal incision. You see implants in the perineal incision, and they use non-absorbable sutures to tack it into the edge of tunica, much like what we do in orchidopexy. It was found to be successful in preventing erosion. Regarding fibrosis, there's various methods to kind of help to remove those fibrotic tissue from the shaft of the penis. One of them is Otis urethrotomy, commonly used by urologists in the past before TURP to widen up a narrow urethra before placing a resectoscope. But I like the vacuum therapy because it's non-traumatic and it avoids most of the need of excavation and increase the penile length. And so as urologists, we want to use malleable because it's more reliable. But what if the patients like inflatable prosthesis? What could we do? Zacharias studied subsequent upsizing of malleable to inflatable after median of 4 months and found that patients happier. Satisfaction rates increased from 80 to 90%, which is big because those of the 20% initially unsatisfactory patients, half of them become satisfactory, and they also get longer prosthesis. Now, if everything fails, definitions varies, and for example, in the systematic review, it's defined as less than 1 month, so it's early. Late, it also varies a bit, and in this paper originally described by Zacharias, it's at 6 months. So it's quite a big gap. 6 months already, much of the fibrotic process has occurred. Now, moving on to what if everything fails? Probably we can ligate bilateral cavernoso artery, but it's just a case report. Now, I want to present an experimental technique that's called scrotal decompression. Recall that we have lots of treatment exists, multiple lines. That's because none of them are mostly effective. None of them are very effective, while does not cause high rates of comorbidity, that is erectile dysfunction. And it seems that second-line therapy, that is shunting, seems to create problem for implantation. We're kind of basically tripping our foot. So scrotal decompression was proposed. It's very simple. It was done in lithotomy position, perineal incision. We identify the corpora, we open it up, and then we drain all the blood outside. We even put in a sucker inside to suck all the blood out, which I think is pretty smart. And then we irrigate it, and then we close it back. This was proposed by Baumgarten in 2020. That's on 25 patients. Mean 71 hours of priapism, which is very delayed presentation. All failed aspiration, half of them failed distal shunt. It found that there was a 100% success rate following bilateral decompression, and half of them regained spontaneous erection, which is quite remarkable. Yeah, the mechanism they proposed, because it was done via a perineal wound, so it can achieve like a more complete dilatation. They inserted distally and also proximally, whereas in the distal approach, we can't really insert it very proximally because of the curvature yeah. Yes, that's correct. That is still the recommended approach in the guideline. This study is only proposed as experimental technique, and it is retrospective.
If you could get a really good patient, but I actually learned that AR first one I had. I did exactly that. I did the distal shoot. It's just putting the hair down. I've never had this happen. You can get it direct. That's like that was sage advice.
For my learning, Alex, does dilating the Hagar commit you to a prosthesis or not necessarily, but can they still get erections? Curiosity.
Your voice.
Okay, sorry. My question was trying to understand how the cavernous artery is not completely like ruptured after you stand dilated. Just wondering if you do that remotely, will get in trouble with active arterial bleeding. That was kind of like my question.
So it's the same dilatation as with the penile implant. So it's not a consideration really that we're worried about in terms of dilating for implants. So I also wouldn't be concerned here. And plus, it's a very small opening and you have a contained space. So the worst case scenario is you convert it to a high flow, which would represent damage to the artery. So and a high flow is, a semi-urgent thing to manage. There's plenty of time. There's not going to be a risk to the patient, but you can transfer in terms of a temporary embolization if required, but sometimes they just resolve on their own conservatively.
I could only add one point here is that with the penile scrotal approach, while it seems the dilatation has not surpassed the distal dilatation, it actually closes the tunica, which might explain why there's a better rate of erectile function afterwards, because the tunica is closed after the procedure. Now, moving on to stuttering priapism, it is very biochemistry heavy. I have simplified it down. Stuttering was first coined by Emon in 1980, describing a cohort of Jamaican patients with recurrent ischemic episodes. Right now, it's defined by the AUA as recurrent ischemic episodes with or without meeting the 4 hours criteria. It's very common in sickle cell disease, up to 45%. Usually presents rather early. I have boiled down the biochemical aspect into very crystallized manner, so for better understanding. Recall that erection is all about parasympathetic stimulation, nitric oxide pathway, CGMP release, and this causes arterial vasodilatation. CGMP is broken down by PDE5, common target we utilize in erectile treatment, erectile dysfunction treatment. So it seems that PDE5 is central to erectile function. But regarding the PDE5, is there homeostasis mechanisms? It turns out there's some sort of regulations in the PDE5 and is regulated by what we call basal CGMP. It is not those CGMP we secrete during erection. It is those that secrete by endothelium at baseline 24 hours. So if there's less basal CGMP, there's less need to break down PDE5, and the PDE5, the less need to break down CGMP, and the PDE5 level decreases. And vice versa, if there's more CGMP and there's more PDE5. Now, animal experiments with mice found that priapism or SCD models, there is more hemolysis and there's more the nitric oxide is being consumed by the free hemoglobin. And therefore, there's a decrease in nitric oxide, decrease in CGMP, and as a result, there's a decrease in PDE5 expression. As a result, if there's any stimuli, sexual stimuli, and the surge in the neuronal CGMP will be unopposed, and there will be unopposed erection, and as a result, priapism. Regarding recurrent illness like stuttering priapism, we can approach this situation is work on prevention and work on the early treatment. Preventive medication still has weak evidence and high side effect, like a significant side effect profile. One common agent used is a low-dose PDE5 inhibitor, which breaks down the basal CGMP and cause an increase in expression of PDE5. As a result, when there's a surge in the neuronal CGMP during erection, it will not be unopposed. In general, these medications still have the evidence is weak and side effect profile is significant, especially some of them has hormonal mechanism, anti-androgenic properties. So utilization of them requires shared decision making. Now, recall that anaphylaxis was a patient with high risk of anaphylaxis will be given EpiPen. Like if they have early signs, they can inject themselves. This is also a proposed treatment in stuttering priapism. The principle is that the patient has to be competent. And then it is self-injection. You inject a low dose, you repeat it 2 to 3 times. If it fails, you still have to go to emergency room. The risk is injection site reaction and the side effects of systemic injection. The principle of managing acute priapism in the sickle cell disease is to not delay urologic intervention for the hematological aspect. We don't do cold irrigations, advise against any cold compress if asked, because that will worsen sickling. Collaborative care and patient education regarding recurrent priapism. Now, moving on to ICI-associated injection. These patients are at increased risk of having priapism, and early treatment is possible. If it's less than 4 hours and it's more than desired, is defined as prolonged erection. Now, the treatment difference is that here we don't need to aspirate or irrigate because phenylephrine alone is associated with almost 100% success rate to take down the priapism. If it's more than 4 hours, then treatments as per the usual priapism pathway is indicated. Sorry for the fine print. Just want to move on to non-ischemic priapism. So the treatment is different here. It's not a urological emergency because up to 60% of them resolve spontaneously. We don't want to overtreat. We want to observe them for around 4 weeks. And if it persists, we'll repeat ultrasound, and then we can proceed to treatment. Ultrasound helps to localize the exact lesion because this allows the radiologist to choose the exact site of access, which is usually contralateral to the lesion for better internal iliac artery access. Now, if the non-ischemic priapism recurs after treatment, the next line is to repeat embolization using some permanent materials. And if it's still refractory, then surgical treatment is needed. The take-home message of the presentation is on the treatment algorithm of ischemic priapism. We have to treat early, because otherwise it's associated with erectile dysfunction. We should be aware that penile prosthesis in priapism is challenging and associated with more complications. Early is the preferred manner, and we can consider stage approach. For stuttering priapism, the focus is to use preventative medications if the patient agrees, and to advise on the home management. Prolonged erection following ICI is treated with injection, phenylephrine injection only, and cavernoso artery embolization is the mainstay for non-ischemic priapism if it persists after operation observation. Thank you very much. I would like to thank Dr. Flanagan for his guidance and welcome any questions.